She has a weightlifting background for very, very long. She was competitive. I think she was a provincial athlete. Um, Provinces are like states in Canada, but and just much smaller. And she presented with um, like a thoracolumbar pain, rib cage pain along the costal margin, and to throw everything else in the loop, umbilical pain right above the umbilicus. And hers was interesting because she only came to me because her medical doctor made her go try a case of physiotherapy before they move forward with anything. And we just everyone, a lot of our patients, it's really funny. They just say, even they'll answer a phone, they're like, hey, I'm in physio right now. I'm like, I'm not a physiotherapist, I'm a chiropractor. But it doesn't matter because their idea of what chiropractic is much different than what we do. So I don't care what they call me. It doesn't matter. And so she's like, okay, cool. I know a guy. I'll give it a try. So the only thing is the umbilical pain and the rib pain has been going on for 1.5 years. And it worsened 1 month ago, 1 month up on initial eval. She is recently, how old is she? I think she's like 28. Yeah, she's 28. And she recently had a child 8 months ago. And this is where it's pretty cool. There's a lot of stuff going on. So she would get tenderness upon palpation to the thoracolumbar junction right at T11 and T12 spinous, even at T6 as well. So we kind of use that mostly as as an audit. I like to see, you just pick something that is provocative or whatever, their concern. It could be a squat. I want to improve a squat, make sure you look at the squat. Super simple. So we pick something and I just do tenderness because that's what she came in for. That's her concern. And she hasn't been working out nearly as much just simply because she had a baby and things like that. And that's actually kind of what worsens it. If she's sitting and carrying the baby for too long, that would kind of worsen things. And she would just get this strange abdomen pain every once in a while. It wouldn't happen that often. Some days were worse than others. I couldn't reproduce it. So at this point, as a chiropractor, I'm just if it's abdomen pain, I can't do shit for that, man. I'm sorry, I don't know what it is. But I could treat the thoracolumbar and rib pain, assuming that they're two separate things. That's the best thing I could do. I'm maybe they're related, maybe they're not. Let's assume they're not, because that's under my my skill set, and we can go from there. Because there's a lot weirder things that can happen with the human body. So the radiating of pain would happen along ribs 10 and 11, and then occasionally into the umbilicus. So if you guys look up the dermatome of T12, it goes right to the umbilicus. I don't know if you guys are studying for boards or anything right now, but yes, it does. So I'm I wonder if this is one of those zebra cases where is this a thoracic disc issue? So all of these things that are coming up in a history, these are things that I'm diff-dying right off the bat. I'm it's very unlikely. It's the lowest part of what my assumptions are. However, there's this abdomen pain. How could it be related to the spine? Because there's also spine pain. So let's put that at the bottom of my differential. And then right at the top of mine is usually facet. It's just what we're good at. I know I could treat that really well. So those biases come involved. I'm like, okay, it's easy to assume this because it's a safe assumption. Plus, even if I were to treat it, it's not unsafe to do. And then like you could clear things out as things don't respond, right? Like that's what practice is all about. And then so then I asked, deep inhalation creates sensation or discomfort into the low back. Again, like this has been episodic for 1.5 years and only worsening since the baby started. And she's gotten ultrasound and x-ray already for this specifically. So I did a thoracic Kemp's test, no pain with thoracic Kemp's, but tenderness on the spinous process. So that already takes facet syndrome off the table for the most part. You could still have irritation there that isn't worsened through like movement and extension, because facets also can get stretched with flexion. So I'm like, okay, well, let's maybe not take it off. Like it could be, instead of like a compressive irritation, it's like a flexion irritation of the facet joint. Or it could just be simply like the musculature in the area. Whatever the case may be, I check it and I keep it on the back of my head. I did Milgram's test. So I don't know if you guys know Milgram's test. It's basically like you lay on your back, you lift your feet about 6 inches off the table, like a hollow position or whatever. I do that. In DNS, they do that for diastasis recti. And because she was pregnant, I checked it for diastasis. Thankfully, because she was a lifter, and I think she got a cesarean, actually. Let me double check. I can't remember. I think she did get a cesarean. She didn't get diastasis. So she just had like some prerequisites that protected her against that. And like really I did like a thoracic range of motion test. Like there's not a lot of thoracic tests out there. Like you could do, there's just not rib compression, stuff like that. Like it's a very hard region to test orthopedically. So then I just had her move. Like I just did thoracic range of motion stuff. You can't separate the lumbar too well, but I just do it seated. And then it would reproduce pain into the mid back and the rib cage with right lateral flexion and flexion. And then I just look posturally. I'm not a huge posturalist, is what I call them. But I'll look at stuff, and there was a little bit of like spinal blocking, like chunking of the spine. I do it like in the sense of like FRC at like big parts. So like she would have it like from T6 down, and then like her cervical spine. So I was like, well, maybe she's just not moving through these facets, and she's like twigging and like just overloading these certain blocks because of these like huge segments that were just like chunked together. And what's nice, again, here in Canada, because I can only speak to that, is that I was willing to be like, let's assume this is thoracic facet, maybe thoracic disc. I'm willing to write a referral because she has a health spending account. She's like, I just want to make sure it's not anything else. I don't want to do that. And we can't write abdomen MRIs, but we could do spine MRIs. So I'm like, can we just try a little bit of things before we move even in that direction at all? She's like, okay, fine. That's cool. Whatever. So I just treated her, just kind of going from what we can. I just treat the musculature of the area of the scapula, because like if it hurts her while holding the baby, maybe I can kind of free up some movement here instead of here, so that she can kind of like at least divert some of the demand that her body needs of her every day to other parts of the body. Like it's just like that amortization of load. And then I worked on her thoracic erectors, and this one's pretty cool. Do you guys know Philip Snell? I'm sure. Yeah. Okay. Yeah. I did DTM. dermal traction right to the thoracolumbar region. Had her doing some prone Mackenzie extension stuff. Sometimes I'll use cups and then have them do like segmented cat-cow stuff, and then just see what feels better, right? Like, what can I do to create a stimulus to dampen the brain's response to whatever it is causing pain. Because we can't change tissue that much, so I can at least change input. And then just kept trying that. So I did it for a couple of weeks. It would get better, then it would worsen, then it would get better, and then it would worsen. And then we started talking more through treatment, and I found out her mom had cancer and died within 2 months. So she was just like super anxious that this was way worse than it was. And she wouldn't work out. She wouldn't exercise. She wouldn't rehab because she was scared it was worse than what it was. So I'm like, let's just try a couple weeks. Let's just see if this works. It would get minimally better. So then I was like, all right, let's do a thoracic MRI because you're willing to pay for it out of pocket and use your health spending account. And you're very nervous that it's something worse. I did not think it was a thoracic disc. However, I was unwilling to take it off the table simply because of, like, why would you? There's just like no point. Like, you could assume that you could still treat it. And like, again, like, who knows? Maybe you have that one case that like it's symptomatic. Thankfully, our president of our association, I also coach him as like I coach CrossFit every once in a while, like once a month, just to get a free gym key. And he goes to the gym, and I was like, hey, how often do you see thoracic discs, symptomatic thoracic disc case? He's like, I've never seen one in my entire career. And I was just like, okay. I think I might have one because it's just a weird presentation, but maybe. He's just like, you know what I have seen though? Dural tension. And I was like, what do you mean? He goes, after pregnant women get an epidural needle in their spine, sometimes the body just heals it up and it causes pain after. And I was like, do you just dermal traction that area and then like move? He's like, that's exactly what I do. And I was like, okay, cool. I've been doing that. Fine, whatever. Maybe that's going to be what makes it better. So we just keep doing it. I'm like, sometimes you just got to like squeeze the most juice out of that orange kind of thing. Like, get as much before you start adding other things. So, and again, we don't do much. Like, we use our hands and we exercise. That's pretty much it. I adjust her. She doesn't like getting her neck adjusted, so I just do the thoracic adjustment just because there's already chunking. So maybe I could just put in movement because that she can't access on her own. And then I do like very segmental, like cars, spinal cars. I do it with the wall. I do it in cat-cat, like in a quadruped position. Like every week I would try a different way to segment to see what gives her the most amount of movement. And I would just like try it. And then COVID hit again, the gym. So we had to like move our appointments around. So that would like also slow things down. So then she's just like, okay, I'm getting in to see my medical doctor. I'm going to see if she can add an abdomen MRI to your thoracic MRI. And she's like, okay. So it took a lot of convincing for her medical doctor to write this abdomen MRI. And because she's just like, it's for sure not that. And like, even if it was, what are we going to do about it? And just send you a specialist or whatever. And I didn't think it was either. So we finally got it after like, just because you're just like, you could do all of these things at once while you're waiting for imaging and things like that for those appointments. You could still treat. And that's just what we did. So like, while you're waiting for all these other things to happen, you could still continue to do what you're doing. And we finally get the MRI. She has a like weird, like, I'm not, it didn't say, I don't have the MRI report on me right now, and I didn't see it actually, but she has like a strange hyperplasia on her liver. They think it's benign, but she's on the list to get another MRI next year just to monitor. But it doesn't add up in terms of that being the painful stimulus because it's on the left side, right? The left umbilical region, and no thoracic disc on the MRI of the thoracic spine. So she goes, the medical doctor goes, "Are you happy?" Like, and she's like, "Yeah, I'm happy. Like, I know that everything's fine." So now, because there's no like serious things on imaging, she fully leaned into exercise. I have on doing a strength programming, on doing, yes, just 3 a week strength programming. And the only things that worsen it are like a lat pull down with like that extra extension through the thoracic. So I'm just like, okay, cool, just do that. And then on the last rep, hold for 15 seconds to see if we can just dampen the pain response by adding like, you're safe. We know you're safe. And maybe we can just dampen the like pain response, the alarm response to those positions. And gradually, she's just like, yeah, I don't really get the abdomen pain that often. I don't really get the ribcage pain. It's super low, happens every once in a while. She's just like strength training now. And I still treat her as if like dermal traction, segmental cat-cows, the wall one that we do, like a Jefferson almost. And then strength training, like super simple. She has very poor control of like thoracolumbar flexion. So I'm like, all right, perfect. McGill curl up. Here we go. Plug that one in. And like, I just give her tactile feedback to like compress the thoracolumbar junction into the table and encourage her to do the same thing at home. And we're just moving forward. Like, pain that is dampening. You're taking things off that would normally create pain off the table now, taking away those those threats, and things are getting better. But it was only until, like, this is where sometimes imaging is a treatment, right? Like, you now gave her the confidence, and I'm not a huge believer in imaging. I think we could have done this a long time ago, but her buy-in was so poor because she was like convinced something was bad. And you're like, here you go, it's fine, let's load. And she's like, okay, cool, that's fine. But that was like, it was a very, you have to validate their feelings and being like, it could be an issue, let's explore it with you, but I hope you will at least meet me in the middle ground. And then we found out that everything was fine, and she's just like slowly getting better. And like, I didn't want it to be bad in the sense of like, I wanted her to have her answer is what I wanted, because once she had her answer, at least she was willing to do the next step. Like, but you just had to take off all these other options off the table before she even wanted to go there. This is someone who's like an athlete who was refusing to work out simply because they were just worried it was something else. So you have to it was a perfect example of where you have to validate where they are, validate their experience, and then at least take those things off before they'll even go towards the actual treatment of what will get them better. And like, now she's just like, yep, see you next week. And then we'll like see how I can progress you more. It's also because she has like a lot of benefits here in Canada. So she's just like, I just want to use them before the year is done, which is really nice here in Canada. And so it was just kind of like, now we're just getting her into like loaded extension slowly where it doesn't hurt. I'm like, well, if this hurts with a lat pull down, can I take away and just do extension of the thoracolumbar junction on its own? And will it cause pain? And it doesn't. So I'm like, you just keep adding these movements until eventually like nothing hurts anymore. It's just, That's all you have to do. And it's super simple, but just tedious and long. Like this was how many visits now to get to this point. God, 1, 2, 3, 4, 5, 6, 7, 8, 9 visits to get to this point. And you just talk to them. That's kind of it. Like sometimes that's the therapeutic part, because she could have really just done all this stuff on her own, but the relationship you've built with your patient is probably, I think it's an undervalued and undereducated. Like they just don't teach you that that's like a healing portion of what we do in school. Like we just get so focused on the things we can do to a patient as a student, because you're like, oh, now I could do this, cool, now I could do this, cool, now I could do this. But like the healing part was just being there for them and just like guiding them through the process of like what is difficult is just dealing with this uncertainty and dealing with this like painful experience. Yeah, because
I think even with that too is just the like the way that we're trained in school is, you know, somebody has progressive back pain over the like that allotted time, and then, you know, history of cancer, like it's very easy for us to just jump to imaging, which ended up being what, you know, was going to help her the most. But also just like, I think for us getting comfortable with giving that trial of care before we just jump to like all the big bad scary stuff. Obviously it's on our radar, but like getting better, and you know that kind of ties into like the last case study with like, you know, we're not going to come out of school being great at this, but you know, trusting ourselves enough to like give a trial of care and like let the patient know like they're going to be okay, or that we believe they're going to be okay.
Honestly, sometimes it's just hard to convince a patient. Like I was trying to not, I'm like, you don't need imaging. Like, I don't know how else to convince you otherwise. But yeah, sometimes you just have to, like, it's just kind of what they need.
Would you, so I guess my question for you would be the same as last time, you know, leading up to this, would you have changed like your initial approach to this, like by getting imaging earlier, or, you know, like, were you okay with?
We couldn't. It was like my hands, yeah, I was like, I would have, like, I was so confident that there was nothing, but she wasn't. And sometimes it's just like read them and weep kind of thing. Like, I'll show you, like, I'm almost positive that there's nothing. If we could have gotten it earlier, I would have just to speed up the process, because then she would have been lifting far earlier. But that was because I knew she wasn't convinced otherwise, though. Like, you'll get a feel for certain patients that like they really want imaging. Like they just want it. Like I've had to convince patients otherwise far more often than I would like.
Yeah. Corey, Jared, you guys have any questions?
Yeah, I mean, that was an interesting case. So for one, it was a thoracic complaint, and we have palpation, like motion palpation, depending on what you like to do, what you have learned from the docs that teach that stuff. We have Sheppelman's. We rule out rib fracture. She came in with an X-ray, and that's pretty much all you can do. So you had a pain audit on palpation, and then you had some functional audits, like she had pain holding her child, as well as some decreased segmentation. So like those are the things you attacked, and it's so interesting to hear, even with their confidence going in that there was nothing going on that was pathological or sinister, she still had trouble accepting that. And that was the main difference in her treatment for her to get better, was to just say, you know, you're okay, and to get into the gym and start working out again. But you know, looking or hearing about that case, that was everything that, you know, all the docs that, you know, I've learned from in my career at Logan would do the same thing. Pain audit, function audit, attack them, get them moving, you threw it all out here and it was still just there, like not
It's not,
changing.
it still wasn't enough. Yeah.
Right. It's crazy.
You'll get those with shoulders a lot.
Really?
Well, because like people are like, I have a tear, or like even your orthopedic exam would say that they have a tear, and then you're like, you're right. Oh, okay. So half the time I have to ask a patient, I'm like, if we get imaging, what is it going to do for you? And then they'll be like, well, I'll know I have a tear, and I'll be like, will it change what rehab you do or anything like that? And then they'll be like, will it? And I'll be like, no. So why do we need imaging? Like, what does it matter? Like.
Right.
So, and it's free here, right? Like, it's like, and I still don't want to do it because it's because it's a little bit of an ego thing. Because you just be like, we don't need to do this. I want to show you that we don't need to do this. But also, B, it's like there's like the costs don't affect me in the grand scheme of things, but at the same time they do, because like I don't know what it's like in the U.S. anymore, but like if a patient didn't have coverage, you're going to do that anyways. But then you have someone with like a massive health spending account. They're like, no, I'm going to get an MRI. And then they do it behind your back, which happens way more often than you would like. And then they're like, yeah, I'm going to go see a surgical consult. And you're like, you asshole, you didn't even try like a little bit of rehab. So yeah, you get it. Like shoulders are the worst too. They're also very fickle. I call them like they're the Goldilocks law. It's like a little bit too much is like just lights them up again. You'll go back a couple steps, and then too little, you'll just do nothing. It's super. They're just slow cases too, but yeah, imaging's a very it creates a huge dichotomy with clinicians in general. I find, I mean, and patients, like sometimes they just want to know, and you're like, this is not going to do anything for anyone. But yeah, that's it's hard. Like it's a skill to be able to convince a patient that they don't need something like that, especially when they have the means in front of them.
Jay, you got anything to add?
Not really a question, but I think like that was just an awesome case to see how like reassurance doesn't come in like a one size fits all type thing, right? Like there's different ways to reassure a patient, and it seems like there's a trend of trying to, help with like patient education, talking to like, like you're able to move, things like that, like you're going to be okay, or like this is going to be something that we can have a positive effect on. But in this case, like you needed what it kind of fights at, where it's like you don't need the imaging. Like the imaging might be nocivic and like make it worse. But in this case, imaging was actually positive for her, where it helped reassure. It's like, all right, nothing is bad in that, or like serious pathology there. It's like, okay, I can move. So it's just kind of interesting seeing that, because like, for us, like maybe in school, like they push like imaging a lot, but like for us, we're like, all right, like imaging when it's necessary. And like we don't want to create more problems by getting imaging, but like in this case, like it kind of challenges our bias, where it's like, no, actually it helped.
Well, it's funny because like man, I remember my first year coming out of school, I was like, I'm never gonna write imaging. And then the second year came, and I was like writing referrals left and right. I was just like, oh God, like I actually got to make sure like all of this stuff is working. And I wanted, like, I fought, like I would try 8 visits before I would even send them out for imaging. Like, and I think that's far too long. Like if nothing's working in 3 visits, 4 visits, at least start looking into it. Like getting the process sorted, or like something. Like you should get a little bit of change. If not pain, at least function.
So how often, that brings up a question, do you question your initial trial of care like plan for the interventions that you use or anything else, especially when you don't see them for a week?
This is pretty interesting to me because like I remember being a student and you write care plans, and I can guarantee a lot of students hear this care plan once a week for 4 weeks. Then you go to 2 weeks, and then you go to 3 weeks, and then you check up in a month, and then you're done. That's like the typical treatment plan. we don't write treatment plans like that. I actually go by, I go from like, I don't book those out. I go 1 week, check in the next week. If they're like 10% better, 1 week again. Like I'm changing my treatment plan all the time, because I don't think it's that clear cut. And I think like being comfortable with that, it makes it easier. And it also doesn't come across as salesperson-y. Because if you're like to this patient, be like, all right, we're going to treat you for 4 weeks, for week after week, and then we're going to 2 weeks, then we're going to 3 weeks. It already sounds like you've created this plan, this made up plan, not even based off of their progression of things. So like, I think it's important to be able to just be like, you know what? Like, I think we need to close the distance of how far our appointments are, or I think we need to actually see how far I could take you along between appointments with these exercises. And like I don't think, I can't even remember the last time I did that like treatment plan thing, other than for motor vehicle accidents, because there's like provincial protocols you have to follow, but that's the only reason why I do that.
With that, like for instance, with the case with the thoracic pain, you don't see her for another week with the interventions that you gave her on day one, and she's, no better, or maybe 10% better. How often do you change your direction of treatment as far as the interventions that you use? Or do you keep doing the things that you're doing and hope that next week she's a little bit better?
I just change position, or I change loads. Like sometimes I go more, sometimes I go harder, or like very rarely do I book more than 2 visits a week. Very, very rarely. Mostly because I think it's important to make patients feel like they could do a little bit of their own care at home. But again, after the 3rd visit, I'm already thinking like, if nothing happened, like sometimes it just takes a couple visits. Like that's just as simple as it is. I don't know why, and I have no basis for that other than like my experience. But if like by the 3rd visit, it's not a little bit better, I'm always shifting. Like always, like I'll add another intervention, or I'll be like, you might need to see someone else for this, or we might start getting you towards seeing our sports med doc or whatever. But it's just based off of their progression. Like it's a hard question to answer, because it's almost as if you see it in front of you kind of thing. Because like what's pretty cool is like some patients will be like, you know what, I felt great for 4 days and then the pain came back, and then you're just like, okay, I just got to close the gap. Like I got to just treat you in between a little bit more. Or like I was good for a week, and then that's when the pain started. I'm like, okay, good. A week is fine. Like we could still keep doing that. And we're like, and I actually have patients, like I push them out quick, and that's like something you'll learn. And I think every student tries to push them out faster than they would like. It happens all the time. And they're like, that like 2 weeks was just a little too long for me. Like it's so like, okay, cool. Like you just go with what they're feeling too, because you have to validate what they're going through, right? So I'm always I don't just like always just do the exact same thing, because like that doesn't work. You have to make it harder. You can always make everything harder. Like that's the easy part. And it's kind of like that idea of a weed cookie. You can always take more. You can't take it back. So think of that with treatment too. You can always do more, but you can't take it back what you've given, kind of thing.
For sure. I know you said you had something to do at 10, right?
I have 10 minutes still. We're good.
Okay.
If you have any questions.
I'm just going to stop the recording and then real quick.